Okay, 12 o'clock. I started the tape going. We should be set. Okay, so we finished up on this one, doing the stress testing, the various types they can do. And so when talking about collaborative care of ACS, so think of the things we do to give these people comfort. So you're going to sit them upright. These people are orthopnic. They come in with trouble breathing. What's your instinct? Sit them up. We give them O2. Typically, it's to keep O2 sats over 93. We'd like it higher. The more O2 we're getting, the better oxygenating we're making the red blood. That's, the blood cells that are circulating in the body. We do continuous monitoring, and we do the serial EKGs. Don't forget your IV access. You've got to have lines that function. And if it's an iffy one, chuck it. If it's been in for a couple of days, chuck it. We don't want the patient to get phlebitis and then a clot and then have another embolic situation. We don't want them to get infections. We want the line to work when we need it for drugs. We have to be able to, know that we're going to get everybody in, So.
Hey, Jane.
Yeah.
Tori Parker, Tori, she has a different last name now. She has a different last name. She needs to be let in.
Okay, I just let a whole slew of people in. Let me see.
Lauren, the same way, Jane.
Yeah, they're all, it says they're joining. They've been joining, so I don't know if they can't get in.
She's in. She's in now. Thank you.
The member just jumped up big time.
Yeah, I think they're just, it's probably slow, from when I approve it to when it clicks in. Okay, so the IV access are important. Nitroglycerin, sublingual nitro is big. People have anginal pain, it's the first thing we go to. And if it's not relieved, they say, wait 5 minutes, give it to them again. In the hospital, we're doing 12 leads along with it so we can see what the nitro is doing, if anything, to their rhythm. High dose statins, if this is somebody that comes in and we've done a blood on and we find that their cholesterol is really high and they're not on a statin or they've been non-compliant with the one that's been ordered, then, we're trying to get them back on that regimen. So we have them taking those high dose statins. The MS we give them, we'll talk about MS when we go all through the individual drugs, but the MS we give them is for pain relief for sure. But MS is good because it decreases the work of breathing. And we're careful with that. We want to maintain a good respiratory rate, but it can be for current pain they're having if their blood pressure can tolerate it, or it can be for residual pain. Now, sometimes when people have cardiac events, we resolve the infarct, whatever it is, and they'll still say, when you ask them their pain level, they'll say, well, I got this kind of funny pain here. It's not bad. I'd say it's like a 4 out of 10. Is it like your other pain when you came in? No. We're doing serial EKGs. We see no other changes in anything. And it's thought to be residual pain, from whatever incident they just went through, whatever their situation was, their anginal attack, whatever it is. Some people just have residual pain. And if we can give you pain med and it takes it away, we know it's not angina, right? Because anginal pain is not going to go away from morphine. It needs a better vasodilator than that. So residual pain is something you will see somebody treated with. We don't want them to sit there with pain because pain is going to increase people's heart rates, right? Somebody's in pain post-operatively. What do we notice? Their heart rate is up. So we don't want to do that in a person that's just had an underlying cardiac episode. All right, so antiarrhythmics as they're needed. There's always something written PRN, lidocaine for 3-beat, 5-beat, whatever it is. And then usually if you give it, you have to hang a drip of some sort to follow. So there's always something there for antiarrhythmics because we expect them. Okay, so vital signs, continuous pulse ox, that's all standard stuff. Keeping them on bed rest. We don't want them expending energy that they don't have the cardiac output for. So what's the collaborative care? Well, unstable angina with negative markers, what are we going to do? They have double antiplatelet therapy. They have aspirin and heparin. They have glycoprotein inhibitors. I don't know if you've heard of these. These are more procedural. They use them when they do procedures. Very potent inhibitors. And they use them before a cath, during a cath, when we don't want someone to thrombose. We don't want that clot that we're messing around in the heart, and it's going to release some plaque and it's going to become thrombotic and kill them during the procedure. So they can give it definitely in cardiac caths. Let's see, what else? Sometimes people during a cath continues to get angina. So we'll be taking care of somebody, the angina is under control, it's unstable, it's their third or fourth attempt, and they'll say this person needs a cath, even though it's not primary treatment. We warrant it in this situation because they've been in the ED 4 times in 7 days or something. So they may put that person in. Percutaneous coronary interventions, not so much for the unstable angina, unless, like I say, this person has been in frequently. You know, this is the 4th time you're in this month, what's happening here? And we think they've tweaked the drugs, they've put you on something different, they're, you know, they've got a whole different regimen going and still you're coming in. So they may say this could be more than what we think, you know. Maybe they have a lot of collateral circulation and there's really a bigger problem underlying this, more blocked vessel than we think. So then with STEMI or NSTEMI, the NSTEMI, if you have positive markers, if the NSTEMI, all your troponins are up, everything's saying, yikes, this was a bad heart attack, your EKGs are suggesting it wasn't a STEMI, but boy, you did some damage, then they may say, you know what, we have to go in and do something. They have reperfusion. When we can do a PCI right as someone is infarcting, they come in the hospital, we run them upstairs, we get it in, we can have some reperfusion from the area usually distal to the clot. We might not get it all back, but the furthest part, this part that's been without oxygenated blood flow the longest, is probably dead to rights. But anything in between, pardon me, sometimes we get that back. So a CABG, when are they going to do a CABG? Well, we used to do coronary artery bypass grafts on anybody with big blockage in the heart. Now that we have stents, and they've been so well perfected, and they really do a good job, and we've mitigated all the consequences of them, they would rather go to a stent because it's minimally invasive and it can work just as well. It doesn't cure you, but it's going to buy you some time. If somebody has 3 vessels or more, they're looking at a CABG. You might find a doctor that says we put 3 stents in so-and-so today, but you know, they have to do something and the patient's not willing to have a CABG. But typically major vessel disease of multiple vessels, they're going to tell you your best bet of survival is to go with a CABG. If they've done stents before and they failed, you're the one that they always collapse on, you're the one that they clot off on, you're the one that has every horrible side effect of a stent that we hope people never have. If it's happening to you, then they're going to say stents are not for you, let's just go do the CABG. It could be that you're complicated by other history. You know, you have brittle diabetes on top of it, you have high cholesterol genetically, you have other things that make you, for you, the risk is better if you go have the CABG. All right, so emergent PCI, first-line treatment for a STEMI that's confirmed. In a perfect world, if you come in 90 minutes, we say that's the best. We'll get you in and do it and you'll do the best. It's gonna find the blockage for us when we do the cardiac cath. It's gonna tell us about the vascular condition. Consider this as something. If we're gonna put a stent in one of those tiny little vessels I showed you on the musculature, on the surface of the heart, imagine how tiny the stent is. But if we know that this has been hardening, this plaque in there has been hardening, what's to say when they put this stent in and expand it, it's not going to rupture the vessel? So this helps us when they do the cath first, they can see the vascular condition. They can see if there's some kind of give to this vessel, that if we put this stent in, are we in for more than we bargained for? And then we can't get this patient open fast enough. It gives us an idea of ventricular function. It's going to tell us other things. Now, we started out doing stents, they were bare metal. The problem is that, you know, we still had okay outcomes, but over time, the body sees it as foreign and it comes along and it's going to put the fibrin and the, you know, plasma and everything all over it and try and sequester it for you because it's foreign. But we don't need it to do that. Then it's clotting off the stent. So then we go to drug-eluting stents, which is pretty much what they use all the time now. And this eludes this, it has this surface to it that won't allow anything to encapsulate it and cover it over. Now, are there people that react to that drug? I'm sure there are. And so for those people, they're going to say, it's still clotted off on you. You had some adverse reaction to it. You need a CABG. Stents are not your thing. You know, by and large, we have good results with stents. So we can also do the intra-aortic balloon pump if you're stuck someplace and you're shocky and you have to get to somewhere where there's help. We can give you inotropes, and they can support your heart with something beta selective like dobutamine, because it can increase your heart rate, but not your systemic vascular resistance. The more we talk about drugs, you'll see there's some that are for people that have no systemic vascular resistance and need support from the rest of the body. And there's always a possibility for CABG, which is not a fun surgery by any stretch of the imagination. All right, so here is, let me take you off screen share a minute and see if I can't get us on this site. We shall see. This is a site, I don't know if you've been on it or not, but it's, let's see, come on. Let's see if it will come up. Yes, it's coming. Yes, it is. Okay. Commercial, hold on. A phone ad. Let me get to share. No, it's not showing. Oh. Okay. Nice try. It just doesn't share sometimes. You can't see the video, can you? No. Sorry, guys. Not today. Let me get you back. Yeah? Okay, sorry. Sorry about that. That one's not gonna work. It's a YouTube, it should, but obviously not today. So, okay, it's one you can see, and it's just a simple YouTube video, but it shows you about the stents. So what they do is, obviously this is a very simplified picture of plaque inside a vessel. And they first go with the first catheter that goes in, and it assesses the vessel and its give, because it's got to be able to give. When they first did balloon angioplasties, all they did was go in and stretch it open with a balloon and came back out. Now we know to go in and leave a stent there. So if the vessel is responsive to it, they will open up the balloon that's inside, and this stent, all these little junctions here, have these little prongs that will go into the wall, the vessel wall. So they open it up, and it opens like this, and they take the stent out, and your patient does better. So it works really well. I mean, it's got its issues, you know, like anything else, but it works well. All right, here's an image pre and post. So, geez, I'm sorry. So here, pre is a coronary artery. You can see it's very, very small. Now, remember how tiny these are to begin with. You know, think of your hand, the size of your hand, and the size the vessels have to be on it, and to see them blown up like this is blown up thousands. Okay, so here it is. Here's your blockage. Here's your open line, and here's your blockage. And this is after the stent. So it makes a big difference, you know, makes a big difference. All right, so what are the advantages? Why do we want to do it now? Well, it's not surgery. There's less anesthesia. The patient can get up and walk. I mean, depending on their insertion site, if they go in through your groin, they're going to make you park yourself for a while to be sure that you're not bleeding and the site's fine and, you know, the pulse is good on your distal foot and all of that. If they go in through your hand, you have a little bit more mobility. They still have to make sure you clot and everything is okay. But you're up and moving. Sometimes they're not even in the hospital 3 to 4 days. I mean, Lewis says that's on the outside, you know, 3 to 4 days, but sometimes they're gone sooner than that. And versus a CABG after an MI. I mean, people were in, when I first did CABG patients, they were 2.5 weeks at least in the hospital. Now they're down to inside a week, you know, but it's a miserable surgery. It's miserable. And they can return to work faster. And, you know, it's not a CABG. So if people need it down the road, they have a fallback. So what are the complications? Dissection of the dilated artery. This is a problem. A dissection, you remember I told you, is not going through all the way. A dissection is going into one layer of the vessel, and you create a channel that blood can go through. It gets diverted from your main vessel down this channel. This is not a good thing. People die of dissections, so we don't want a dissected artery in the heart for sure. Abrupt artery closure, that can happen. The stent, for some reason, just closes up, and the patient becomes instantly symptomatic and is infarcting all over again. The rupture of the coronary vessel, that has happened. I've had patients with that, and they have to, of course, go in and try and crack you open, and to set that up and get you in there fast enough, it's not something that happens in 5 seconds. And don't forget, they've given you these potent glycoprotein inhibitors that are not letting anything clot. So there's nothing to stop once that vessel is ruptured, that you're just pouring blood everywhere. It's not a good scene. You can have a stent thrombosis. We hope that you don't, and they give you have a drug-eluting stent, so it should not clot. You're on these potent antiplatelet aggregators, and so you shouldn't clot. But can you clot? Yes, you could. You still have plaque that could have been disrupted by this PCI. And even if it's not collecting thrombin and plasma and fibrinogen and everything all around the body when it's going, it could be a significant amount of plaque itself that it could still cause you an MI. It could get caught in a vessel somewhere as soon as the heart beats. So you just don't know. The risk of infarction or stroke is big from that. You figure we're operating on the surface of the heart. If this plaque dislodges at all and it's out in circulation, all it needs is one heartbeat, and it's up your aortic arch and into your brain with this fleck of atherosclerotic plaque. So it's, you know, in cardiac caths, they do use dye, and it's tough on the kidneys. It's tough on people with allergies to dye, but it's tough on your kidneys to break down. So if you're somebody who had maybe not renal insufficiency, but, you know, your kidneys are being watched because of other drugs you're on or whatever, or you've had renal insufficiency, this could put you over the edge because it's the dye is really tough on the kidneys. They usually preempt it by giving you some bicarb or something, see if they can help the caustic nature of the dye. So you can restenose, and people feel so much better after they've had it that they feel fine. There was a daytime talk show host. I always forget his name when I go to say his name. It was, I'll tell you, Regis Philbin. And he had multiple stents. And then he finally had to have an open CABG. But he was on New York TV for years, and I think nationwide TV also. But he had stents put in, and they were doing one of those shows on the road kind of thing. And I don't know where they were going, Bahamas or someplace. And he was saying, I'll be fine. I had a stent. I feel great. I feel this and that and the other. And they told him not to go. And he went to Bahamas and he restenosed. So they had to airlift him back to Florida and have procedures done and whatnot. So they do. People feel better. They don't think they feel invincible, but they can restenose. And we always have to watch for bleeding because of the anticoags they give them for the procedure. When they come back to you, they're not just going to stop with a little bit of pressure. It takes a while. Okay, so thrombolytic therapy. So now we're talking people with a STEMI, and if PCI is available, that's what we want. But if it's not available, what do? We're trying to intervene to minimize the damage that can be done by this infarct. So we want to get to it and either break up that clot, not let you extend to another wall, not let it get worse. You know, we're trying to control this infarct. So that's what we want. Again, if they say, what's your dream sequence, medicine will say, oh, 30 minutes would be nice. You get pain and are with me and I have you on TPA in 30 minutes, that would be great. It doesn't happen that way. So all TPA is given, this is thromboplasminogen activator. It is all given IV. You need good lines on your patient. It's Retavase and Activase. They still use urokinase. It was one of the first ones. They still use streptokinase because it's cheap. That was one of the first ones. They use tenecteplase, the TN case. The patients have to be watched carefully if they are on TPA. This is no joke of a drug. All right, so what are the guidelines for this? Well, you have to be a candidate, number one. So your chest pain has to be less than 12 hours is kind of a give or take window, but that's really the benchmark they're using. 12 lead EKG has to confirm a STEMI. And then you can't have any of the absolute conditions. You can't have an active bleed somewhere. So if you are in the hospital already with a GI bleed and you infarct and your hospital doesn't do cath and they're looking to do this, it's a no-go because you're bleeding already. And this is going to make it 10 times worse. If you have an aneurysm, a diagnosed aneurysm, if you have an arteriovenous malformation in your head that they know about, no. If you have a brain tumor, no. Benign or otherwise, doesn't matter. Closed head trauma, you're the trauma case that's in the ED and you've got a bad head and it's closed and we don't know your altered level of consciousness and now we see you infarcting and we don't do cath here. We need to ship you out anyway because you have a head and a heart problem. But the point is, in that scenario, you would not qualify because you have a closed head injury and we don't know what's happening. A previous cerebral bleed of any kind for any cause, no. A recent stroke, whether it's embolic or hemorrhagic, doesn't matter. And if they suspect you have an aortic dissection or a cardiac dissection of any kind, no go. Because this will make you bleed. People can bleed to death from this who don't have any of those things, never mind people that have it. All right, so what do? They get baseline labs on your patient. You need 2 to 3, I would tell you 3, viable IV sites. When I mean, I would move up to people's upper arms because the vessel's bigger and it's not used often and I could always get a good vein up here in the arm. And it will last me through my TPA. Frequent, careful assessments. It's breaking down whatever it perceives to be a clot. So you have to pick through your patient's history. You didn't have a laparoscopic chole. You know me, I'm under the gown. What's the scar? When did you have your lap chole? What's this by your belly button? When did you have a laparoscopy? When did you, I mean, you have to go picking through everything. You know, what do you mean you had a toe surgery? I thought you said you had no surgery. Well, it was just my toe, I had a bunion. No, that's surgery. You know, that's a condition. So it's gonna go after anything that is newly healed or anything that resembles a clot and dissolve it. So you gotta watch your vital signs because they'll bleed internally and the only way you're gonna see it is an increase in heart rate, decrease in pulse. We do the serial EKGs, we're watching the oxygen. Listen to your heart and lungs. Are they bleeding into the pericardium? Are they bleeding into the lungs? Am I having trouble here? If they start to reperfuse, it's unbelievable. The ST segment goes right back down. We're doing those serial EKGs, and the ST segment comes right back down to baseline. So it's pretty cool to see. They have instant relief of pain. So the closer you can get it to the onset of pain, the less damage is done. It's really pretty cool. They will have a rise in CKMBs, and this does make sense. If you're drawing troponins, the trops will go up in 3 hours. So you're thinking, oh my God, the trops were high, now the ST segment's down, now look at my trops again. But why? It's because you have undone this clot. So everything beyond it is now opening up again, and that's releasing everything that was either ischemic or dead. So all of that's coming into the blood. So the trops are gonna go up even though it's not a new infarct. If it's a new infarct, along with the trops going up, you're gonna see your ST changes again. I'm sorry, that's my phone, that's not on the ringer. And you're gonna see the trops go up again. You're gonna see the ST segment go up again. You're gonna see your patient saying, I have horrible chest pain all over again. And you'll know if they're re-infarcting. And it's usually a couple hours after TPA has been stopped. So they will have reperfusion arrhythmias, and I've told you about those before. They're idioventricular, sometimes a torsade de pointe, which is so ugly. It goes completely around the sphere of the heart, and it's very ugly looking. But if it's in the setting of this, they sometimes leave them and let them work it out. All right, so what are the major concerns for anything is reocclusion. Whether you've had a stent or we've given you TPA, we don't want you reoccluding, right? And that can happen. The chest pain, the EKG changes, everything I just told you. If the patient is receiving thrombolytic therapy, they need to get to a hospital who can do more than that. You know, now that we've just completely dissolved everything and now we're going to go and try and put a PCI in, but that's what they need. If they're reoccluding from this medicine, it's not helping them. So they need to get shipped. Watch for the bleeding. Your IV sites will be leaking blood with TPA. Your patient will ask for a drink. They'll be talking to you and their lips will be bloody. You'll see their urine is bloody. You'll see stool is bloody. All of this is reportable. They will take them off of TPA if they're starting to bleed everywhere. You got to watch their level of consciousness. If it starts fading on you, they could have a brain bleed. So keep careful watch on people with TPA. All right, so surgically, revascularization, we're talking about the CABG, coronary artery bypass graft. And this bypasses the clogged vessels on the surface of the heart. So I mentioned before, imagine, we know how tiny those vessels are to begin with. But now we're taking another vessel and bypassing them, going right over it and giving another source of blood. And they have to do these tiny, tiny, tiny anastomotic sutures of that new vessel to the heart muscle. And any anastomotic site can leak. Anytime you suture, you can have scar tissue. So we're hoping that we don't have scar tissue, and we're hoping it heals and the blood is still flowing. But I'm telling you, tiny. It's minute work. So if you've had unsuccessful medical management, if you've had multiple vessel disease and maybe complicated by diabetes, if you've had a failure of PCI, or they deemed your vessels too brittle to even do the PCI, they're going to tell you you need a CABG. And this is a link I have here. This is very, I won't try it because it's not working today. This is what it usually does. It won't work. So I put the links in there so you can see them. But this one is one done for outside people. It's very simplistic and very, you know, a very rudimentary diagram of a chest and a line coming down to open it, a little sponge washing it, all that stuff. It's very simply explained CABG. So that's for outside people, really. All right, so traditional CABG, the patient has a sternotomy. It's nasty. They're gonna cut down your sternum. They pry open your rib cages. They have to pop your lungs. They put you on cardiopulmonary bypass. They divert blood through that. We'll go through that in a minute. The organs are perfused, so everything's fine, but they're perfused mechanically. So think for a minute how hard it is for your renal patients who have to go on dialysis. Yes, we say we take the blood out, we wash it, put it back in. Not an easy process on the body. It wears down a lot of people. It really is hard for the body to take over time. So this isn't for a long period of time, but don't forget, this is in a setting of an MI, an acute MI. They might have really blown a wall badly. So they're not the most stable person in the world. And now we're taking them in and let's divert the blood and filter it and clean it and keep it warm and do whatever. And then when the heart's ready, put it back in. So it's a lot for someone to go through. You know, they have to be able, again, to withstand the setup of the surgery before anything else. They're out a long time. Okay, so most often they're going to use the mammary artery because it already comes off of a subclavian. And it's just locally a good site for them to take down and connect to the heart. So it works well. That seems to be the common choice. If somebody has had a CABG and then 10 years later needs another CABG, and it's of the same vessels, because after they get new vessels, they want to go out and eat fried chicken again and do all of that. And they come back sometimes willing to have a second CABG. And, you know, what are they doing now if they can't use the internal mammary, if it's been injured from a prior surgery, prior injury or something? We have to go find other ones. We can go to your saphenous vein in your leg. We can even use your radial in your hand. I mean, we can find other things. They have issues more than the mammary, but if the mammary isn't available, or if you need more than one and we're looking for other sources, then we have to dig other places in your body, have those open sites, get those vessels out and bring them up on the heart. All right, so here's our cardiopulmonary bypass. And I know these are always like these two-dimensional drawings but it will get the point across for what happens. So we are bypassing the heart altogether so that we can work on the heart and not worry about anything else. So they take one end and they puncture your vena cava so they can harvest the blood from here. This is going to be an anastomotic site in your vena cava that we have to cover for now. And the blood is going to come out and go through a pump. It doesn't go up over the head, it goes into a machine, but they're trying to show you. It goes through a bubble detector, it goes through an air filter removal. It goes through a venous line ocular, an eye that's looking at it to make sure it doesn't have particulate matter or anything in it. Goes through a pump to keep it going, goes into an oxygenator, and it comes out as arterial blood, as if it's been to the lungs and back. On this side is where they're giving cardioplegics, which is into the heart, making the heart be still. It's paralyzing the heart, essentially. And what is it? It's a solution of chemicals. It's chloride, magnesium, and potassium and all. And the body is lowered in its metabolic temperature so that the metabolic demands are less, and they put in cardioplegia. Now, this blood comes out of here. There is an arterial filter, and it comes down and it goes back in to a puncture in your aorta, which becomes mundane when we talk about aortic dissections, because what kind of injury would be done to your aorta to cause the layers to come apart and create a channel where blood can get caught down? And it's trauma directly to the aorta, which would be a CPB machine, where we're putting a hole through the vessel of the aorta so that we can completely bypass the heart. So that's basically how it works. A roller pump, machines keep it all going. It's kept at a certain temperature, but just like dialysis, cells can be crushed, and so sometimes you have to transfuse people afterwards. There's issues. We have to slowly raise their body temperature. They're freezing after this surgery. And we have to wake the heart up from the cardioplegias, which it's none too happy having been operated on and been still for a while. So you start connecting it back up and running blood through it, you can imagine the arrhythmias we have. But we can get them done. We know they're coming, and we plan in advance for them, and people survive it and come out to the ICU. All right, so it's a good surgical option. And here's a picture of the internal mammary that I think is good. It's got good patency rates. So here's your subclavian here, and here comes the mammary. So they take it out of its spot in the tissue, and they bring it down here, and they bypass wherever the clog is. So they're giving a really good blood supply here. Now this picture is showing us a saphenous vein they've taken out of a leg, and they're hooking it up in here. They can also take from your radial artery. Now that one tends to spasm quite a bit. And remember, the concept underlying all of this is this patient is a bad vascular patient to begin with. We know they have heart disease. So as much as it's being manifested in the heart, you can't look and say, well, then you don't have it in the periphery. You don't have peripheral vascular disease. They likely do. It's not manifested yet, but there's probably some disease progression there. So we have to be sure we can take that radial artery from you, and your hand is going to be okay without it. Are you going to have impaired circulation? And it tends to be spasm prone. So we might have to give you something then to stop the spasms, just so that it works well. So they're going to keep you on statins because we don't want plaque in these new vessels. And they're going to keep you on the antiplatelet therapy for sure. Okay, let's see. So other ones, radial, I just told you about. Gastric artery is a possibility. If they need like 5, they might go down, but there's a lot of digging to get there. That's extensive OR time to get down into your gastric artery and take it. And arteries are prone to spasm because they have musculature within them that veins don't have. So the patency rates are okay. It's not like they close from hyperplasia or anything, but they spasm. You don't want spasming arteries in the heart, so they tend not to use it unless they have to. So this is a YouTube about cabbages, and this one is good. It's better, I think, than the other one. It's kind of slow moving, but I think it would help you if you want to see some of you I know will never work in cardiac care units, and that's fine, but if you want to see really how a cabbage, what they're talking about. So all of this is not a cure. This is palliative care. That's what this is. It's palliative. We can't fix this. We can get around it. We can try and restore blood flow. These are things we've come up with, but we can't eradicate it. There's no way. So women have a higher operative mortality, just as a demographic. And we don't know why. I mean, in the OR, they don't like anybody dying. That's a sentinel event. Somebody dies in the OR. So they kind of put people together with Scotch tape to get them out and say they died in recovery. But they do have a high intraoperative mortality, and they're not sure. Is it that their presenting symptoms are so nebulous that the disease is probably a lot further progressed when they get to this point than met the eye? They just weren't all that, the symptoms weren't all that dramatic, just insidious. I don't know. They don't know if it's to do with the vessels. Who knows? We don't know yet. We'll know soon. I'm sure someone's working on it. All right, other options. Now, as I go through these other options, don't make yourself crazy. You don't get tested on mid-cabs. You don't get tested on T-cabs. But the Board of Nursing is funny about us teaching you about them. So you have to hear about them. So we'll go through them, okay? So this is your minimally invasive direct coronary artery bypass. So they call it a mid-cab, because people were so tortured by these cabbages. I mean, it's a miserable surgery. They bring your rib cages back together again. They're all stretched at the side. They're all wired in the front. They have chest tubes. They're just miserable, miserable. And we're telling you, you're going to get up, vent and all. We're going to sit you in the chair tonight. That's the last thing they want to do. But we get them up and moving quick. So someone said, we got to be working on this minimally invasive thing. What do we do? So they came up with this mid-cap. Now they don't do, it's not for 5 vessel. You have that big a disease, you have to have your chest cracked. There's nothing we can do. But there's no sternotomy here. And the theory is there's no cardiopulmonary bypass. So the thought when you first hear about it is like, okay, how are they doing this now? Now, what they do is they give you beta blockers to slow down your heart. And they take a thoracoscope and they go in through your chest. You have a chest tube. They go in through your chest and they're gonna put mechanical stabilizers through the thoracoscope opening. They take a little piece of rib and they clamp whatever section they're trying to sew. And the beta blockers are keeping the heart rate down. And they try and stitch up an artery. They do all the dissection through a thoracoscope. Not the most common procedure in the world, but it's out there. It's for people that are poor candidates for cabbage. So you say, well, if they're poor candidates for cabbage, can they tolerate their heart rate being dropped so much, their heart being pinched by stabilizers that are going to hold one little section still while the doctor sews on? I mean, they're not the best candidate either, or they wouldn't be having some intervention like this. So they mean in relative terms. Some places do it, it's just, it caught on in some places, and that's, if you want it, that's where you have to go. All right, another off-pump option is called this off-pump coronary artery bypass. Well, what's the off-cab? They do a full sternotomy. So they're gonna open the sternum up. They keep the heart beating. They don't put you on CPB. And they, again, use the beta blockers, slow your heart down. They use stabilizers. Wherever they're looking to suture, they clamp the heart. You can imagine in the OR when you're clamping and unclamping these sections of a live beating heart, how annoyed. I know how ventricles are annoyed just by people doing paracentesis and, not paracentesis, pericardiocentesis and coming too close with a needle and it throws them into VTAC. I can't imagine what it's like in the OR through this. But the heart is very slowed and it's an option they can offer somebody who's otherwise a poor candidate for alternative treatment. They can do a totally endoscopic cab, a T-cab. And this is no cardiopulmonary bypass, which saves them a lot if they're unstable. And it's minimal bypass grafting. You have to have maybe 1 vessel. And it's very precise. And they go in with thoracoscope and all, and they they do a vessel repair. But it's not real popular, but some places are trying to get it off the ground. They'd rather do that than do an open CABG. So options. All right, something else. I alluded to this, I don't know what lecture we were talking about, laser therapy or something. And I alluded to this. I said, when we get to cardiac, we'll talk about laser therapy. This is transmyocardial laser revascularization. Some places call it TMR, some places call it TLR. Doesn't matter, one and the same. Now, they do indirect revascularization. And this is kind of an unusual thing to imagine. They get real creative with these stuff when they're trying to come up with new procedures. They'll do an anterior thoracotomy. So they're going to go into your lung, they'll pop it and put a chest tube in. And then it's usually someone deemed a non-CABG candidate. Now that's across the board, the usual principle. University of Cincinnati does this adjunctively with every CABG they do. So different places, the hospital you work picks up different things that are their routine, but generally it's for people who can't tolerate a CABG. So persistent angina, advanced disease, poor medical management, this patient just isn't doing well. This high energy laser zaps through the ventricular wall and makes a hole from the outside to the inside, which picture how annoyed your ventricle is at that. And then it's counting on angiogenesis. So the same principle we talked about with liver, now we've talked about with coronary circulation, now they're using that application to laser through a ventricular wall. It can be done during a cardiac cath, and it can be done percutaneously. It can be done adjunctive to a CABG like they do at University of Cincinnati. So it's an odd concept. And maybe it was when we were talking about maybe it was when we were talking about stretching the aortic valves. And someone said to me, how do you heal up that hole that we make through the atria? Look at this hole we make. Okay, so now this is your ventricular wall. So how many gazillion, this is probably 1 million times enlarged. Think of your heart being the size of your fist, right? And this ventricular wall, and here's the outside edge of it. Look, they even put fat around it so you know the person has heart disease. Okay, so now they're gonna take this high energy laser and they go through the outside wall and they go straight through all the way to the inside. Now, this laser is probably as thin as a hair. I'm telling you, it's very, very thin. So the muscle can just come back on itself and naturally not leak or whatever. But they do this periodically along, it's not one and done. They do it periodic spots all along the ventricle. And it's going right through. And the premise is that with angiogenesis, this is going to connect and bring more blood supply to strengthen your cardiac muscle. So you can imagine the impact this had when it came out. Number one, people were like, I'm not so sure I want to do that. My patient will spring a leak, and if you do 10 of them, they'll have 10 leaks. They're picturing a sieve, like a colander, the water going through it. So, but when they started doing it in trials, it caught on pretty quick. And like I say, at University of Cincinnati, they say even their CABG patients, if they're bad enough to need a CABG, but strong enough to withstand the surgery, then we'll do these vessels, but while we're in there, they're going to get this, and we're going to see if we can create some angiogenesis in the muscle. Yeah, so it's interesting, but it was scary thought. These people are gutsy, let me tell you. But it's all from understanding a concept of angiogenesis that we know happens in the body and extrapolating it to other areas. Okay.
Hey, Jane, sorry, do we need to know that one, or is that part of, like, because you said certain ones we didn't need to know? Is
right.
that?
Treatments, I don't ask you specific questions about TMR and TLR, but it's stuff we have to present to you. That's why.
Okay, thank you.
Okay, so you probably won't forget it though. It's so weird. It's such an odd thing. But anyway, so drug therapies. Let's talk some drug therapies. So what's the initial drugs of choice? IV nitroglycerin if somebody comes in and they have a BP that can withstand it. Because remember, IV nitroglycerin decreases preload and afterload. It's systemic vasodilation. So it's going to drop the BP down. The problem with that is if the patient is struggling to maintain cardiac output, you're decreasing cardiac output also. So is blood getting through the ostia and feeding the surface? No, you can cause more chest pain. So you got to be careful. Your patient has to have a good BP to have nitroglycerin IV. But they'll put you on the statins. They'll give you some systemic anticoag. They either give you low molecular weight heparin, which usually that's after the fact, after you've been treated for ACS and all of that. Initially, they'll give you heparin, unfractionated heparin, which is heparin that you know. Dual platelet, antiplatelet therapy, definitely. Aspirin and Plavix, or some mixture of the two. The glycoprotein inhibitors, they're 2A and 3B are their classifications, and they're Riapro, Integralin. People go by their trade names rather than their pharmacology names, their generic terms. Beta blockers in the first 24 hours, we have found in evidence-based research that it decreases your incidence of reinfarcting in the first 24 hours. So a beta blocker is good. Calcium channel blockers, ACE inhibitors, don't forget what the ACE does. The ACE inhibitor is going to prevent that potent vasoconstriction of angiotensin 1 converting to angiotensin 2. So this is going to maintain your blood pressure under control. It's going to decrease your systemic vascular resistance, which helps people. If you have an ailing heart, it's hard to push against a lot of pressure to get blood out of the heart if you have systemic vascular resistance. So that was a big stride there. All right, what else? So IV nitroglycerin, we know it's going to improve coronary blood flow. That's why we give it sublingual. It's going to relieve angina. Most times it does, unless you're infarcting. But it does decrease preload. All the blood coming into the heart and all the blood going out is your afterload. And it's decreasing preload and afterload because it systemically vasodilates. It increases your myocardial oxygen supply. What we have to hope is that we're looking at the demand and trying to reduce that. So watch the BP closely. You will drop your BP when you start someone on nitroglycerin. Definitely. They can be hypotensive quickly. It has a short half-life, but you don't want to drop them down low where they're going to go into a compensatory mode. You have to maintain the blood pressure. Keep your eye on it. Maybe they're volume depleted. We don't like to go flooding them with fluid because they have an ailing heart. They're on a systemic vasodilator. You could easily throw them into failure. So you have to be really careful. Your drug is titrated. And the way you do titrations is you don't say, okay, blood pressure, heart rate are too high, I'll up the nitro. And then boom, they bottom and you say, okay, I'll put it back. And no, you have to sit there and say, I'll go up 1 on the nitro and see what it does. And then you got to watch your patient and let it level out and then go like that. There's less need at night because your metabolic condition is changing if your patient goes to sleep. Now, critically ill people are critically ill 24 hours a day. But if they get any chance to rest, which we hope they do because we're trying to get them to restore themselves. You need sleep, it's restorative. We're hoping that they get some sleep at night. So we may have to decrease the dose at night. Don't be thinking, on my shift, they're almost off the nitro. Because come the morning, they're going to get a cortisol release. The metabolic demands are more in the daytime, and the day person's going to have to go up on it. Okay? Think about the action of the drug. All right, so here I'll talk about morphine, and then I'll give you a break. So morphine we talked about before. Now, a couple of things to remember about morphine. We do give it for chest pain unrelieved by nitro. If we think you're infarcting, you've had your 3 nitro 5 minutes apart, not working so good. Maybe the doctor wants you on something else, but in the meantime, they'll say, give that patient a little morphine because it'll take the edge off. Morphine is a naturally occurring opioid. It's full of histamine. Anytime any of you have given morphine IV, you should have looked at your patient because they can very easily have a reaction to it. You have to be careful. It's something you know. You don't just push it and walk out the door. Are they going to have anaphylaxis? Are they going to have urticaria? Are they going to have wheezing? What's going to happen? You got to pay attention. Maybe as a student, that wasn't the focus of where you were just then, but as a nurse, you better believe your instructor knew it and your nurse knew it. So you got to think of that. And some people, after they've had morphine, maybe they're okay with it and they're more trusting of that. You can develop that reaction anytime. So it's very high in histamines. All right, so morphine is going to decrease your oxygen demand, which is what we want. But watch that it doesn't decrease the respiration so much that now your patient's bradypneic, and now what? Now they're not oxygenating enough, and what's going to happen from low oxygenation is they're going to be hypoxic, and that's going to contribute to your patient having chest pain. So think about what we're giving, the action of the drug, what's happening to your patient. So it does decrease workload. It decreases the workload of breathing also. I know students think it's cruel when someone is dying and the doctor will say, let's put them on a little bit of a morphine drip. My students used to always turn to me and say, this is euthanasia, they're trying to kill this person. And I would say, they're trying to decrease the work of breathing. Nobody wants to die gasping for air. No family wants to see their family members suffering like that. We're not in the business of killing people just because they're dying and hastening their death. But if we can make it more comfortable for them, it's better. It's a low dose of morphine, but it's enough to decrease the work of breathing. So instead of this poor soul just all the way to the end, they're able, if they're conscious, to look around and see people and not be gasping and not be suffering. I mean, that I think is more cruel. So it's up to us to manage our patient care, right? So it will decrease BP, it will decrease heart rate. So think of the other meds the patient is on that could be doing the same thing. We don't want a patient where all of a sudden their heart rate's precipitously low and their BP is precipitously low. So be careful, watch the action of the meds. It also takes the edge off their anxiety, which is very helpful. So watch for the low respirations. That's classic with morphine. All right, go take your break. I'll see you at the top of the hour, okay? Okay, guys, I put the recording back on. So we just, finished up with morphine. So you'll see it used a lot, but remember, it's a naturally occurring opioid. All right, what else? Oh, our old friend, the beta-adrenergic blockers. Here we go. So what do we know? They reduce heart rate, they reduce BP, contractility. They're good at decreasing oxygen demand in the myocardium. So they have found in the first 24 hours of the setting of an MI that it can reduce reinfarction and the onset of heart rate because it's dulling that beta-adrenergic response that wants to stimulate your heart. The faster your heart stimulates, you're increasing the work of the heart. Your blood isn't pumping enough. You're going to have symptoms of failure. It's going to backlog up to your lung. So all of this starts the train, and they have found it's really helpful, especially in the first 24 hours. So they will put your patient on beta blockers. And there's a bunch of them here. Other things, well, we talked about the ACE inhibitors. ACEs are good. These are helping with anybody with heart failure, with poor ejection fraction, people that they're afraid really have an anterolateral, a big MI, that they're going to have a lot of remodeling of the ventricle and run them into trouble. It's going to decrease your systemic vascular resistance, which is good. It's helping decrease afterload. So the heart has less pressure to push against when it's trying to pump out of the heart. So it works well for that. Dysrhythmics. You have arrhythmias all through the setting of an MI typically, so we're always on top of it. Sometimes it calms down with one thing and not with another, and they get them on the right combination or the right med that works for them, and gradually we wean them off of it as the patient is more days out of an MI. And some people go home with something PO just to maintain, stability. Excuse me. So arrhythmias can be life-threatening to anybody at any time, so we don't take that lightly. But in the setting of your MI patient who has impacted their ventricular wall and is not pumping well, it's even more lethal. So you don't look at them and say, some nurses will say, if I don't have a strip of it, it didn't happen. If I didn't catch it on a strip, it didn't happen. If you see it, you got to respond to it because the heart's telling you it's annoyed. All right. Lipid-lowering agents, people that have a history of cholesterol, they have elevated triglycerides while they're in the hospital, they have high LDL, whatever the issue is, they're going to get them on a statin. It's you know, and if a lot of people get put on a statin and come off of it, one of the most common complaints they have is bone pain. Their hips ache them, their arms ache them, their thighs ache them. Bone pain is a very common symptom of being on a statin. And what the doctor will say, if you say, I have this horrible bone pain, well, I've reported it to physicians all the time. They have terrible muscle and bone pain. And he says, all right, let's take them off of this one, put them on this one. So they take you off one and they put you on another. And then you do okay on the other one, and it's not bothering you. And then the doctor will say, I like the first one better, so long-term, I'm going to switch you back. Then they go back to the first one, and typically you don't have those symptoms again. So a patient shouldn't come off of their statin to be off it for life. There's a reason they need the statin, so we just need to take them off, put them on something else, try again, try another one. Some doctors don't have a preference. Fine, if this one bothers you, take this one instead. So it's all up to the physician who's ordering. Stool softeners are important. Your patients on bed rest, lack of activity can constipate people. Opioids can constipate people. So straining is going to give them vagal stimulation. They're going to get bradycardic. So we don't want them to be straining with Valsalva. So be sure we're giving them something preemptively so that they go easily. All right, so nutritionally, your patient is NPO with an MI until the pain and maybe accompanying nausea is relieved. Certain MIs have more nausea than others, you know, posteriors, inferiors, it's the vagal stimulation. They tend to be nauseous and vomiting, but they don't have to be. Some people, it's the pain that makes them that nauseous and vomit. So until they're NPO, until the pain is resolved, it's too much demand on the body, and you give them something, they're vomiting. That's more stimulation, increases the risk of aspiration. You know, they're NPO until that's resolved. Typically, when we get them on a diet, it's low salt, low fat, low cholesterol, healthy heart diet. All right, so here's some nursing diagnoses: acute pain, decreased cardiac output, nothing that's, you know, the self-health maintenance is for people that are non-compliant. All right, so what do? This is your patient. What are you going to do? You're going to assess them completely, often, not mechanically. See what they're telling you. They're going to be on nitroglycerin, tabs, if not a drip. They're going to have morphine on board. They're going to have oxygen. We keep oxygen on them all the time. They come in with chest pain, we go to oxygen. Because whatever blood is circulating, we want it oxygenated. The muscle is screaming because it's out of aerobic metabolism into anaerobic metabolism. So we need oxygen to reduce chest pain. Cardiac monitoring from the ED through the ICU into progressive care, they're monitored all the time. So during and after an MI, watch the arrhythmias, realize how dangerous they are. Report any ST elevations on a 12 lead that you see, any changes you notice, any changes in breath sounds. Patients can easily be in failure from heart attacks, so be sure we're picking up on that. Report new sounds. If it's not an S1, S2 that you know, report it. Okay, what else? We let them rest, rest, rest. They have bed rest initially. And even after their cabbage, we get them up and sit them in the chair and we move them back to the bed. We're very, very careful with them. We have to watch for heart failure. You have to watch that you're not increasing oxygen demand in a sick heart. So we're careful. Cluster your care. Try and get them to relax. This person is impacted like you wouldn't believe. They were walking home from the teeter on a nice day and had a heart attack. They were at work and at the office, came out of a meeting, had a heart attack. You know, their life has been suddenly disrupted, and they're facing their own mortality. It's very scary to patients. They get weepy, they get angry, they go through all the stages. It's very difficult. So explain the need for restrictions. You know, we're really trying to decrease the oxygen demand. Anxiety. We medicate people for anxiety all the time. If you find this patient, and some cardiacs are like this, they're afraid to move that they're going to break. They remember what that pain was, and they're afraid if they move to even grab the TV changer, it's going to come back. You got to get them over that. You know, watch what the source of their fear is. Are they so anxious in the morning because they're afraid of the doctor coming in? He's got bad news, he's dying, this and that, whatever. Sometimes they're like just a ball of nerve until the doctor comes, and after that, they're okay. Identify the source, what's the problem here? And then I've even spoken to doctors to say they're a wreck, they always feel another shoe is dropping. What is it that they're most afraid for? Put it on the table. You know, if they're most afraid that the doctor's going to say, you're going to have open heart, talk to them about open heart and what you think the chances are. Get it out on the table so it's not the sword of Damocles that's hanging over them. So, you know, that's the thing. You've got to talk to the patient and figure out the source. Sometimes the source of anxiety is the family. They all come in and it's like they're mourning already. Oh, Dad, you have a bad heart. Did they say, I mean, how close were you to dying? This and that. That's not helpful. People mean well, we know that, but that's not helpful. So watch your family interactions. Watch that the brother that hasn't spoken to his brother in 20 years suddenly arrives on the door and wants forgiveness, and the patient can't handle it. It's too much with what's going on. You know, you sometimes have to intervene and say, this is not the time for this. I mean, this is, you know, watch your patients, see what's going on. Okay. Still more. We say we provide holistic care, which means we do. You don't just say we do. So what's their other need? What's their spiritual need? How are they coping with this? Don't forget your mental health training. They go through all the stages. It's like Kubler-Ross, death and dying. You know, in the beginning, I didn't have a heart attack. I don't care what they say. Last week I was playing golf. Last week I walked in a 5K. Last week I did this and that. It's abject denial. They got to get over that. Then they get depressed. I can't believe I'm however old they are, 58, 64, 72, and I'm going to die of a heart attack. Well, you're not dead. You're not dying right now. We're doing all we can to keep you alive, but you'll see when they go into that depressive stage. You know, they'll be telling the wife or the husband, cancel the travel plans, cancel this and that. They don't see any future. So that's their depression. Then they're mad. You know, sometimes to the wife, you're the one that's always cooking the high-fat food. It's my mother raised us on the high-fat food. It's it's because that's what the family likes. I make the high-fat food and now I'm the one dying of heart. I mean, you'd be surprised how it comes out. Then their anxiety is just, I don't know if I'm here tomorrow. Look at one day I was fine and the next day I was here and look at this horrible diagnosis. What if I'm not here tomorrow? The anxiety creeps in again. And then there's dependency. They want the wife there all the time, the husband there all the time. They can't leave the unit. I'm not ready to leave the ICU. Yes, you are. You're fine. You can leave the ICU. They'll keep an eye on you on the floor. No, but I need to be with all this life-saving equipment. You're fine. You know, they need to realize they have to get back to their life. You have to live while you're alive. And that's hard for them. So the dependency thing comes in. And then eventually it has to be acceptance. And we have to watch what's going on here. Because if they're not transitioning, if they can't see anything else, it impacts their ability to engage in their care to keep themselves healthy. So we don't just say, sometimes they need the priest, the rabbi, the minister, whomever. Call the chaplain, whatever faith they are, call the chaplain, they'll find you somebody. So maximize that support going home. Don't let them think they're flying solo. I get the discharge plan to come in and talk to them again. They need to go over these things with you. And sometimes they say, well, I told them already, I gave the wife a paper. Now, I need you to come in and talk to this patient. I do it with students all the time. Come out here, we'll get the discharge plan. And we go in and tell her, you got to come in and sit with this guy. This is a real issue in this man's life. And it's easy to organize everything, but this family needs reassurance that they're going to be okay going home. So you have to anticipate and you have to advocate for people. You know, don't be afraid to go ask people, make them do things. All right, pre-op CABG. You have to teach your patient about a CABG, and it's not fun. So you have to tell them they're in the ICU at least 24, maybe 36 hours. They're intubated, they're on a ventilator. They could wake up still on the ventilator and they won't like it. There'll be a tube in their throat, but just keep in mind, it's breathing for you. It's helping your new heart get oxygenated blood, and they'll be medicated for the discomfort. Now, we can't give them too much that when we try and extubate them, they can't breathe on their own, but we can take the edge off the pain. Tell them about the chest tubes they're going to have. Tell them about the pulmonary artery line they'll likely have. We'll talk about pulmonary artery lines tomorrow in hemodynamics, but they'll put this big long line through your heart that's monitoring all your hemostasis. So, you know, we're going to tell them all these things that are happening so they're not surprised by it. And you're going to have probably a line in your artery in your wrist. It's not a regular IV line. It's giving us constant blood pressures. If you tell them the function everything has to help them, they usually are okay with it. So just tell them the nurse will be there to make sure you're as comfortable as we can make you. But we're going to push you. We're going to make you get up and sit in the chair the first night. You know, tell them they're not going to be eating. They'll have a tube down. They won't feel it going in. It goes in the OR, but it's to decompress the stomach so they're not nauseous and vomiting. They'll appreciate that. And then when it comes out, they won't like it coming out, but they'll be glad it's gone. Continuous EKGs. If they've had open heart surgery, they have what we call epi wires. They're epicardial wires that can be used to pace. They can be used to defibrillate them. And they're in the heart muscle, the one end, and then the wires hang out through the surgical site. And so if the patient runs into trouble and we have to pace them quickly, we can attach pacing equipment to the end of it. If they, God forbid, code on us, we can defibrillate through the wires. So they'll have epi wires hanging out. Tell them about the incision sites. You know, did the doctor talk to you that they're going to harvest a vessel from your leg? You'll have an incision site on your leg. And it's funny, sometimes I had a student in Dixon precepting probably 3 years ago now. We don't get many in Dixon, but no, it wasn't Dixon. It was the cardiovascular thoracic. And the patient, what bothered him more, every complaint he had after CABG was related to where they harvested the saphenous vein. Nothing else bothered him. How does your chest feel? Oh, chest is okay. I'm good. And chest tubes, how's that go? Oh, I'm fine. Everything's fine. My leg, you know, they went in, they cut my leg open. I thought, well, let him focus on the leg. Maybe he's not thinking of anything else, you know. But it was the strangest thing. The student's like, really? He split here and here. He was pried open. And I don't know. But, and there was nothing they could do for that leg. It bothered him. So, you know, tell them about the other incision sites if they're going to harvest vessels multiple places. What else? They'll have a Foley initially. Activity, they'll get them up. They want to change position. They'll get them up, sit them in a chair, even if they're still vented. They're going to take the tubing and drag it with us and sit you in the chair. And pain control is there. It's PRN. And again, they watch what they're giving you, so we're not bottoming your pressure and increasing your demand, but we're giving you what you need. Because the patient won't comply. You know, they won't do anything if they're too uncomfortable. And we don't want heart rates going up, you know. So what are the complications of a CABG? Well, as I said before, most of it relates to the fact that you've been on CPB. That's the big problem. That can cause systemic inflammation in people. And you already have some degree of that. We know that because you have ACS. So that's not good. Any anastomotic site they have gone to can bleed. They got your vessel out of your leg, you have anastomotic sites in your leg. You have surgical site in your leg where they cut your skin. You have all the anastomotic sites from CPB, from all the sewing of all the vessels, from everything. So any of those could seep because you have been anticoagulated. So that's an issue. You're hawking your patient to make sure they're not dripping blood into that pericardium. So watch that. They can have anemia. Many's the time I've transfused people after CABG because the cells are there, they're crushed. And what do we need? We don't need, with this patient with a bad heart, we don't need to have cells that have decreased oxygen carrying capacity. So they'll give them blood and we give it carefully. The heart's restored now, it should be in good shape, but we don't want to fluid overload anybody. We watch the fluid and electrolytes, that's our business. You got to keep them even. Something's not right, K is too high, too low, we're calling. Got to get this fixed, we got to get it stabilized. Nothing else will work if we can't do that. They come out very hypothermic from having their temperature reduced in surgery. So we have the bear huggers that we put on them, you know, those inflatable blanket things that go on them, and they need that for a while. Your temp doesn't just rise quickly. It's pretty slow to come around. So be sure they're warm, and we're doing that. And always watch your infection sites. The last thing this person needs is for you to be sloppy with an IV and infect them. They have major surgical sites all over the place. They don't need bugs. They don't need UTIs. They don't need, you know, urosepsis. They don't need any of that. So be very, very careful. Changing dressings, maintaining IV lines, all of that. All right, so what do? What else do you do? You're not done yet. This is sick patient. You're busy. So we're monitoring the ABCs. The airway is open. They're not having issues. The breathing is good. The circulation is good. Even once they go to extubate them, can they maintain it? Can they do the work of breathing on their own without the machine? Because now it's going to hit them. Oh yeah, the machine did the breathing when my chest was aching so bad. Now I have to do it. Yes, you do. And now that the tube's out, we're doing incentive spirometer. We're doing all of this stuff. So they have to be comfortable. You got to take the edge off that pain and then be in there and get them going, you know. All right, cardiac monitoring. A lot of times AFib is common after surgeries. It doesn't have to be. Sometimes I'd rather AFib than VFib, but sometimes people have it. It just tends to be a common thing that comes from having surgical sites in the heart. But sometimes they're okay, not a problem. Hemodynamic monitoring we're watching, that's continuous blood pressures. We're doing blood gases. We're trying to make sure they're nice and stable. Watch the bleeding from the sites. Watch the harvest sites. Those are surgical sites you have to look at and change dressings on besides their chest. So watch that. Don't let them develop a DVT. You're going to be looking for that all the time. Make sure you're getting them up in the chair when they're supposed to be up in the chair, back in bed. And now they're calling ICU psychosis, postoperative cognitive dysfunction. What it is people get really confused. They get nights and days mixed up. They've been in an ICU setting that's noisy. You know, there's always alarms going off, machines are pumping and hissing and everything, and it gets them out of their element. And maybe they come back late from their case and they're awake for a while, and then they go to sleep and it's 3 o'clock in the morning and they sleep for a while and they wake up and they don't know if it's night or day. They're tired. They've had a huge insult to the body. All these things going on, emotional worry. They're just out of sorts. So they can get what they call ICU psychosis, and it's also called postoperative cognitive dysfunction. Okay, so then we're talking cardiac rehab. This is a good thing. Cardiac rehab is a chronic thing. The patient doesn't do rehab and then they're done, because this isn't a cure. So the patient does cardiac rehab. They've got to do it. Keep going and going and going. It offers people a way to maximize their ability. Let's get them to alter. I mean, it's comprehensive. They'll give you diet lectures and instruction. They'll give you exercises to do. They'll get you off those cigarettes. People who give up smoking decrease their chance of heart disease by 70%. So if you're still smoking, I mean, you haven't smoked the whole time in the hospital, but if you even have the inkling to go back to it, that's going to stop in rehab. So they'll do all of that. They also have to restore sexual activity at some point in time, if they're interested. Now, think about the patient I told you who came in with the MI when it was found because they were having sex. Not quite the aphrodisiac for the partner of this person to go have sex again, but also imagine this person's feeling, you know, and yet it's not that they don't love whoever this person is, but, you know, this is an issue. So what happens? Generally, doctors go by simple rules as guidelines. Every doctor can be different. Some doctors will say, you know, I'm okay if they are 2 weeks in, 3 weeks in cardiac rehab, and they can climb a flight of stairs. Some of them say 2 flights because they really want them to go through. So that's how many minutes on a Stairmaster even. And they don't have any pain, they're not short of breath or anything, and they're fine. Okay, I'm okay with it. Some doctors won't address it at all. So I'm telling you that the patient will ask you. Sometimes they ask the people in rehab. Sometimes rehab people bring it up. Sometimes they don't, and the patient doesn't ask, and the patient is wondering, am I done for the rest of my life? What do I do? I don't know, and they don't want to ask. You're the nurse by the bedside. They will get to know you with a crisis in their life. So this is something they can ask you about. And you should feel comfortable in talking to them about it. And if you don't know your doctor's feelings on this, then you say to the doctor when they come, he was asking me today about when he can resume sexual relations. She was asking me today about her sex life. Can you speak to her? And put it on them to go in and talk to this patient. This is part of your patient's well-being, and they'll ask you. So just be prepared for that. All right. What else? Sometimes they have them, I have it down here, that they'll tell them to take nitroglycerin prophylactically, just like they will if they tell somebody, if you have to climb 2 flights of stairs to get to your apartment, which some people do, and they can't move just because they've had an MI, then they'll say, take a nitroglycerin at the bottom step and go up the stairs. So some people tell them to do that. They cannot take erectile dysfunction meds with nitrates of any kind. So that's an issue for people if that's what they have used before. Now it's a conversation to have with the urologist and with the cardiologist. Okay. All right, what time of day is it? Okay, so let's talk some pacers. So train keeps rolling. Okay, so pacemakers. You've had some of this, I'm trying to think. Oh, Bridge taught you about pacers, spikes and all for EKGs, right? Okay, so pacemakers. What we're looking at, this is a little electronic device for people who have trouble maintaining an adequate rhythm. And it's a little battery pack device that goes under the skin. We used to always say it was the size of a pocket watch. I don't think people see pocket watches much anymore, but it's probably maybe this big. And they put it under the skin on the non-dominant side. So if you're right-handed, it goes on your left side. And it's a battery source. And then it has leads that go transvenously down into the heart. And if you need an atrial pacer, the lead is implanted into your atrium. If it's ventricular, it's in your ventricle. If it's AV sequential, it has 2 leads. One goes in the atria, one goes in the ventricle. We can also do resynchronization, which we'll talk about, that you have one in each ventricle to keep the ventricles synchronized. So anyway, this impulse is generated by this little battery pack, and it travels through and it replaces really your whole cascade of, atria to AV node to Purkinje fibers bundled his. Okay, so they're accurate and they're precise and they're very, very small now. And they're able to pace 1 or 2 chambers, whatever we need. And now they've done recently a patent for one that has no wires. It's all electronic and it's coded for, they put a little chip wherever you need it, whether it's atrial or ventricular, and the mechanism under the skin is coded for that. And it's gotten FDA approval. We haven't seen it much around here, but I'm sure it'll be coming. You'll see it if you work in that environment. So permanent pacemakers are planted in the chest and threaded down, and the battery is the issue. If the battery poops out, your pacer's not going to work. So they're all NiCads and long-lasting batteries that they can put in, and they recommend that you change them about every 10 years. The research has shown that the life of the battery is like 15 years. So they say have everyone come in at 10 and change it out. So you're not somewhere where it fails and you die, because that could easily happen. You could go into a ventricular arrhythmia. So what else? They're set to demand. Most of them are set at a certain number. If your heart rate drops below that, it's going to kick in and give you a beat. And that's just, it has a sensing feature. It can tell when your heart's beating well and not when it's not. So it works pretty well. So any kind of erratic condition that we can't otherwise straighten out, that's going to be why you need it. So your SA node isn't working. You have AV blocks, that's an issue. You have trouble with your ventricles. You have, look at the myopathies we've talked about that don't beat real well. Maybe you need a ventricular pacer to keep that straight. You need regular beating for heart failure patients, whatever. Sometimes people have tachyarrhythmias and we put pacers in to block the tachyarrhythmia. So it can work you know, it depends on what your patient, most times it's to maintain a heart rate that keeps dropping, but it can go the other way too. All right, so here's what it looks like, kind of, sort of. Here's your little unit with the battery in it. Here's your little wire that goes in your subclavian, and it's threaded down here. This is an AV sequential. So this is going into the atria, and then another one down into the ventricle. So it will be timed at a set rate to be sure you're getting a beat. And that's for your whole complex. Okay, what else we got? So cardiac resynchronization. So this is what I meant when we have dysfunction of the ventricles. So this is synchronization where we have a lead in both ventricles, and it's to synchronize them to make sure they're beating. You know, the lub-dub, we need them beating in sync. It's not helping if they don't. So it improves ventricular function because it coordinates the flow of blood. It's not erratic. It's not that the right atria is beating before the left atria is. That's going to interfere with cardiac output. So it's especially good for these people, these heart failure people that have conduction delays and ventricular issues and all of that. So a lot of times in a heart failure patient, a cardiomyopathy patient, they'll put an ICD into an internal cardiac defibrillator in also. So temporary pacers, thank God we have them. These happen, you know, you've seen all these dysrhythmias we've taught you. Well, if you look up and you see your patient is in 2nd degree heart block type 2 and they're floating in and out of 3rd degree, we need to do something quickly. And we need a pacer put in. This patient, if they're in 3rd degree heart block, they're going to die. So we need to do something quickly. So in the meantime, even though Maine is a hospital that has a cath lab and we can run you down and have somebody go to procedures or something, get somebody to put a pacer in you, what can we do in the meantime? There's 3 types. We have transvenous, where maybe you've just had an MI and you're having some conduction issues and they don't know if they're going to improve or not. They'll drop a wire. They call it dropping a wire. They drop a wire down and the lead will go transvenously. And the battery pack is probably hanging in a little, like a Holter monitor bag, you know, a little bag, and it's hanging on your IV pole. And they set the settings and this little temporary wire is down there. So that's a transvenous one. It's temporary. Either we think you need a permanent one or we're going to try you on this, and every day they'll drop the power you're getting from it and see if your heart kicks in on its own. If it's not, they'll put the power back up and schedule you for a permanent one. If, as your heart is recovering a little, it's coming back and your heart's able to do its own rhythm, they're going to let it do that. So they'll take the temporary wire out and let you go on your way. Now, the epicardial ones we talked about. You have your open heart surgery, and we have epi wires that are in the heart muscle in surgery before they close you up, and they extend through the surgical incision to the outside in case we need them. So that's your epi wires, in case you need pacing. And transcutaneous is your non-invasive ones. These are the ones they peel, almost, they look like the pads on a AED machine. You know, so the pads peel off, they're adhesive, and you put one on the front, you put one on the back, and it will pace your patient from the outside. Not a comfortable proposition by any means. So let's talk about this external pacing thing. So here is, one's on the anterior, one's on the posterior. They put it on the lowest possible current voltage to do the job, but keep the patient comfortable. You have to give your patient something, analgesia, sedation, something, because the whole time they're like this every time it beats. It's awful. But if you're in complete heart block, they're going to do that. If they can't get a wire in quick enough, they're going to do that while they get you where you need to go to get a pacer. So you have to tell the patient what to expect. They're going to put these pads on you. You're going to feel like an electric jolt. It's okay. This is what we expect. It won't be for a long time. I'm going to give you something to take the edge off of it, because they're going to get anxious. What's going to happen? They're breathing faster. Their heart rate's up. They have all these issues going on, and we're increasing oxygen demand on the myocardium. So you have to control what's going on with your patient. Let me give them something. Sit with them if they need it. They're nervous wreck. I feel like I'm being electrocuted. I can understand that. This is what we're doing. The doctors are setting up. They're on their way. They're going to put a pacer in. Do you know people who've had pacemakers? You know, talk to them and let them know you're there. They're frightened. They're frightened. So they're jolted by current. It's not fun. It's not fun, but it works. So when we're monitoring regular permanent pacemakers, they have to be monitored. They have to be. We don't take anything for granted. So they work well, but they have their own issues. And if you're not paying attention, they'll put a pacer in and don't just say, oh, thank God he's got the pacer, he's good. He might not be good. So you can have a failure to sense. You've seen those rhythm strips, failure to sense. So it does not recognize spontaneous activity. It's not sensing anything that's happening, and it's misfiring. That's a problem. We don't need electrical impulse where it shouldn't be. That's not a good thing. You can have battery failure. This tends to happen when we have the little battery pack that's hanging on the IV pole, not the one that we implant into the patient. That's got a long, long battery life. But even on cardiac floors where they have pacers, if you've had clinical on them or you worked on them or whatever, it's like when people have 24-hour monitoring that they can walk around with. They change those batteries every 24 hours, even though the battery is still good, because they don't want you walking around and not get the tele. They don't want the battery to die if the half-life is, the life of the battery is 35 hours. They're not going to wait till hour 34 to change it. They do it routinely the same time every day. It's a lot of wasted batteries. Yes, I agree. But we're running the insurance that your battery isn't going to poop out and we're going to miss tape on you. So the same thing here. They'll change the battery out in your little pack that's hanging off your IV pole if you have a temporary wire in, because they're not going to run the risk that it's not going to work, and then you're in trouble. So you can have battery failure. You can have a faulty lead. So they put the pacer right in, and it didn't work real well at first. They jiggled the wire, they replaced it, whatever. It's been doing okay. Every now and again, it's a little faulty. This is a bad wire. Get this lead out of here and get me one that's working, right? Its sensing is set high. That's a problem. It dislodges sometimes. We tell people when we put a wire in, don't move your arms and hands a lot. That's why we put it on the non-dominant side. Don't move around a lot. It's got to knit in there a little bit into the muscle. So don't be moving around all the time. Sometimes it dislodges, can happen. Sometimes the issue is failure to capture. So this is an insufficient charge. It's not producing the contraction. The charge is there and the charge is there, but it's not capturing. It's not doing anything on the muscle side. So in the temporary one that's hanging off the IV pole, is our power up enough? Do we have enough amps? Do we have enough voltage going to make something happen? Not if you find it's not capturing. You don't. So you can still have the battery failure and all of that lead failure. You can have any of that. Sometimes the body recognizes this foreign wire in the muscle and it starts going after the wire and it coats it over thinking it's encapsulating it and saving your life. In the meantime, it's not going to capture because it's completely coated over the wire. So that's an issue too. So it can be a number of things, and it's not going to end well for your patient. So you got to be watching to make sure it's working the way it should. Okay, so when you're monitoring it, what do? These are invasive pacers we're talking about now, the run-of-the-mill pacer somebody comes in with. Yes, they have a risk of infection because we've cut the skin. Absolutely. We hope we've mitigated that. We've scrubbed the skin. We hope anyone taking care of it is being respectful of that incision and not contaminating the patient. Can you have a hematoma? Yes. And you will see it when you're assessing the site. It will be a big raised firm. It gets indurated like it's a big firm area that's a hematoma. You can have your sense and capture issues. You can have a pneumo. And part of this is because it depends on who puts the pacer in and where they are when they do it. They usually do it with ultrasound guidance, something. But otherwise, they're digging around for your subclavian. They go by anatomical markers where it should be, and then they're digging with like an angio, trying to get in there. So as they're poking around, what's behind there is a lung. They can very easily pop a lung, trying to dig around and find your subclavian. So if there's any question, we always have a chest x-ray afterwards for placement. What else? If they're doing ones that are AV sequential, they can perforate the septum. which can be a problem too. So, you know, it depends. They usually get a good feel of how it went when they inserted it, and the notes will reflect how they think it went. If they had to do it several times, if there was a lot of manipulation, if there was a lot of bleeding, et cetera. So you'll usually find it reflected in the notes. Okay, so prevention, what do? Pre-pacer insertion, they'll probably give them some antibiotics. And then post-insertion, we're gonna get that x-ray, make sure it's in place, and just check the rhythm. Don't take for granted it's gonna do its job. You gotta look at it. Look at that insertion site. See if they have a hematoma. See if it's healing. See if it's bleeding, if it's leaking, if it's whatever. Make sure it's working, okay? We get them out of bed after insertion, but we do not want them raising and lowering their arm initially. Okay, what are you going to teach them? Limited arm on the insertion side, limited arm initially. Don't go out. I had a guy went out one time, had it, went from 6A, having procedure, down to have a pacer and was sent home. And he was back in the ED. And I had a student in the ED who had him, and I thought, they just discharged this guy a couple hours ago. He took his kid to the park and pushed them on the swings all afternoon, and he dislodged his pacer. So be careful, you know, think of the things you have to teach them. It's important. Reportable symptoms, if they go home and they have fever, if they have redness at the insertion site, if they have to have routine checks. And most of it is done, you can do it now with the cell phone, that there's an app you program into your phone and you hold it over your pacemaker and it gives them the readout they need. People can do it through their cable lines at home. People who have the old-fashioned rotary phones, you can do it through an old-fashioned rotary phone, but you can do it through phones, but they have to keep the appointments and do the random checks of the pacer. Follow-up appointments with the doctor, very important. The goal is we're trying to improve their quality of life. We're trying. So they have to buy into this process, okay? All right, what do we have? 10 minutes. I would like to say, don't worry about it, but we have to start on cardiogenic shock. And it's not so bad because you've had some of this already. We've talked about this. So let's look at it. What are we looking at? Ineffective pumping, systolic or diastolic function is the problem. Doesn't matter. It's going to decrease your cardiac output. And we've talked about all the challenges with that. You decrease cardiac output, you impair tissue perfusion. What do I tell you about the vessels on your aorta? Blood isn't getting to the head. Enough blood isn't getting out to the bottom, to the body. You drop your BP, and what happens? If you're less than 80, you're not perfusing kidneys, you're not perfusing mesentery. You start with all these problems with impaired perfusion. So it's a problem. Now, decreased filling into the heart is going to decrease stroke volume. You have a leading cause of death from MIs is cardiogenic shock. It's really, really hard. You understand what's happening, but pulling somebody out of it is really hard. All right, so causes are systolic or diastolic dysfunction. Doesn't matter. It's all going to affect the cardiac output. If it's systolic dysfunction, we're looking at, dilated cardiomyopathy, an MI. If it's not moving blood forward, it's not. If we're looking at diastolic, we're looking at a cardiac tamponade. The heart can't fill well. Ventricular hypertrophy, cardiomyopathy like restrictive or hypertrophic, it's the inability of that heart to fill. So that's a problem. Any of those patients we've been talking about could be a candidate for that, and have this poor cardiac output. Okay, so what do you see? The symptoms are very similar to your patient with heart failure, because what's happening? Your cardiac output is affected. So your heart's going to try, your body's going to try and help you compensate and speed up your heart rate. This is not helpful. Your cardiac output is low, so you're hypotensive. This is not helpful. You have a narrowed pulse pressure. But what is the body doing? It's going to increase your systemic vascular resistance. If the body is left to its own accord, and its own resources to do what it's going to do. When your cardiac output drops, it's going to release your neuroendocrine hormones. It's releasing epi and norepi. It's going to cause peripheral vasoconstriction, because what the body knows is, I have to get blood to the vital organs. So let me shut down, clamp down the periphery and shunt blood to the heart and the brain and the lungs, so this person has a chance. And that's what it tries to do. Increased systemic vascular resistance increases the myocardial workload, because the periphery is shut down. And now this heart that's having a hard time getting an output now has to go up against a system, peripheral system, that's closing down, clamping down. So it's really hard. This increases O2 consumption. This is not what this patient means, not what they need at all. So the diminished pumping, what does it do? If blood can't get out, where's it going? It's going back to the lungs. So your patient's breathing faster, they have crackles, pulmonary congestion in the lobes. When we talk about invasive lines tomorrow with Swan-Ganz catheters, you'll see they have increased pulmonary artery wedge pressures. This is a pressure reading we take in your pulmonary artery, where blood is coming from the right side up the pulmonary artery to the lung. And those pressures are increased because there's pulmonary vascular resistance. There's all this collection of blood that's not going forward. Blood has to move unidirectionally forward in the heart. And when it's not, there's problems, big problems. So now this patient had an MI, whatever they had, so the muscle can't pump and help you. And the body keeps trying to send blood, and it's not coming in one side, it's not going out the other. So what do you see? What else do you see? Cerebral perfusion is impaired. We've talked about this, that the blood coming out of the heart is not getting up that aortic arch, not sufficiently enough, so your patient has anxiety. And that can be from the shakiness from the neuroendocrine hormones too. But they get confused, they're getting agitated. It's not them being nasty, it's the brain saying, not enough. The signs in the periphery, they get cyanotic. Their hands clamp down, they're cold, they're pale and cyanotic. They get diaphoretic from the epi. They have a weak pulse, they're clammy. I mean, this is not a pleasant presentation. When you see somebody in it and all the pieces are together, you're like, yeah, this is not good, not good. Decreased bowel sounds. Blood is being shunted by the neuroendocrine hormones to the main organs of the body, to the brain, the heart, the lungs. So what happens to the mesentery? It's not getting perfused. So you're doing your assessment and you're not hearing bowel sounds like you did before. So you know physiologically what's happening. The thing is, we have to act. You have decreased renal perfusion. What happens? Starts the whole RAS syndrome, right? And what does RAS do in the end? Your angiotensin 1 goes to 2. Your 2 releases aldosterone. So you have sodium and water retention. You start losing your K. Your perfusion at your juxtaglomerular apparatus is decreased. So your kidney starts holding back fluid in the distal tubule. Don't make urine yet. Something's going on here. Our circulating volume is decreased. We don't have much of an output from the heart. So let's not make so much urine. Let's reabsorb into the peritubular capillaries and hold on to this. And so now you have decreased output. So, the plot thickens, right? There is no test for shock. There's no blood test. There's nothing we can do. We have to understand the setting the patient is in and understand physiologically what's happening to them. So the cardiac enzymes will be up because they've had an MI. The TROPs are up. The BNP is up. Remember this beta natriuretic peptide that the heart releases when there's changes in pressure. So that's up. BUN and creatinine are up because your kidney's not being perfused. Your 12 lead EKG is going and it's showing you a sick heart. Your chest x-ray they're watching the pulse ox. And then we do all the hemodynamic monitoring that we're going to talk about tomorrow. So that'll give you something to look forward to. Yay, hemodynamics. All right, so what's the collaborative care here? What are we looking to do? and then I'll let you go. So the goal is restore blood flow. And by doing that, restore the balance between the oxygen supply and demand. Is this easy to do? No, because this patient's in cardiogenic shock. Can we just say, well, the BP isn't good, let's give them fluids? No, because they can't pump it well. I mean, this is a sick, sick patient. What can restore this blood flow? We either have to do a cardiac cath, do an angioplasty, get some stenting in there, open up these vessels. We have to do revascularization if you're someplace that doesn't do a stenting. We have to replace your valve if that's the problem. If your valve is shot and not helping us regulate blood flow, you know, these are the things we've talked about that we have to get a hold of. Let's find the culprit and see what the most aggressive action is, what we can do to get this patient back on track. Okay? So that's a lot for you to think about. I will see you, pardon me, tomorrow morning, your last day of class. Can you stand it? Who's out there counting on this last day of class? Nobody's out there. Hello, nobody. Okay, guys, long day for you. A lot of work, I know. But I will see you in the morning. You are